In this module, we will be talking about the signs of labour, early labour and the latent phase, active labour, induction of labour, and when to call the midwife or maternity assessment centre when you are in labour. The beginning of labour can be obvious, such as strong contractions or a big gush of amniotic fluid, which is the water surrounding your baby. But for most women, the signs start out in a much more subtle fashion. You may feel overly tired or the need to frantically clean, but changes in your patterns of behaviour is often a signal that changes are taking place in your body. You may feel a dull ache in your back, abdomen, usually quite low down, almost like period cramps or pains, or feeling that aching in the top of your legs. Or you can feel that in all of those places. You may also notice a heavier jelly-like vaginal discharge, which may be clear, yellow or brown, or have some blood staining in it. And these signs are the show or the plug coming away from the cervix as it begins to soften and start to change shape, ready for labour. Your waters may break, which releases the fluid from around your baby. They can break with a big gush, but it's often more common for them to trickle and for you to be unsure if it is actually your waters or a show or discharge. You can put a pad on to catch discharge or water, so it's easier to determine exactly what it is. The waters can have a sweet smell to them and should be clear or pale yellow. If you're unsure, you can call your midwife or maternity assessment centre to discuss what is happening with them. Labour can start with regular contractions, which are like Braxton Hicks, the tightenings that you have in pregnancy, but feel stronger or have more of a pattern. However, it is more common for them to start slowly and have a really irregular pattern to them. They may stop for periods and restart as your body gears up for labour. So do try and rest and conserve your energy if you're feeling tired. These are all signs that labour is starting, but everybody is different and every labour can be different for the same person too. To help labour to progress, it's a good idea to keep well hydrated and to keep eating plenty of small snacks very often to fuel your body. It is also good to keep as comfortable and relaxed as possible, as this will raise your levels of a hormone called oxytocin, and oxytocin is needed to power your contractions. It's very natural for this to happen as your body wants to birth your baby when it feels in the safest place to do so. And it is usually at home when your body and mind feel calmest and safest. Once your labour becomes established, you will find that contractions are no longer irregular, but coming in a pattern around 3 in every 10 minutes, lasting for around 60 seconds or longer. You will most likely need to focus when they come and breathe through them.
So as Karen explained, early labour starts in a very different way for everyone, and the progression of your labour in its entirety, it's more like a continuum. So as midwives and clinicians, we split it into different parts. But for you yourself, you won't really know that you're coming out of one part of labour and into another. So I think it's important to explain that it can stop and start even when you think you're in active labour, and it's really good to get some rest when it does stop. Now, active labour can be best explained by the onset of regular contractions. And when we mean regular, what we mean is they literally come like clockwork. So they're 3 minutes, 3 minutes, 3 minutes, or there or thereabouts. And they're no longer incoordinate. So they have a really rhythmic pattern to them and they're evenly spaced. Most hospitals and midwives will use vaginal examinations. So that's where we actually use fingers into your vagina and we check by touching your cervix how far apart that cervix and how dilated it is. Now, as a rule of thumb, one part of the diagnosing active labour is that the cervix is around 4 centimetres dilated. However, everyone's different. And when we're making that assessment, we need to base it on that bigger picture. So not just what the cervix is doing, but the contractions, how strong they are, how frequent they are, how long they're lasting. And we're listening to the mother and her story, but we're also looking at the behaviour of her as well. And that can tell us an awful lot. And we want to know as well about different labours, previous labours, and how they progressed. So we'll always take into account mum's behaviour. So for an example, the sounds that she's making, how she's breathing through contractions, how distracted she is, how focused she is, as well as how many centimetres dilated the cervix is. So the active stage of labour is often referred to as the first stage of labour. And that's what's divided into the two parts. So first stage of labour, and you've got your latent phase or your early labour, and then your active phase. And we call it active because what's happening is your cervix is now actively opening, baby's actively moving down. So during this stage, the cervix is often thinned down from being a thick, rigid tube, about 3 centimetres long, and it feels like the consistency of your nose. And it's softened and it's thinned out in consistency, so it feels as soft as your lips, but paper thin. So once the presenting part, be it either baby's head or their bottom, has started to apply pressure to your cervix, then we know that it's favourable. So it's paper thin and baby's head's really well applied and the cervix is opening. And it's also lovely and soft. If we look at how the cervix opens, so we talked about how it's a 3 centimetre long tube. So this rudimentary knitted uterus is really excellent at showing this. So this is your cervix, and this is what we feel when we do these vaginal examinations. And it's 3 centimetres long, and it's actually part of your uterus. So as the contractions are happening, what happens to the uterus at the top is the muscle fibres actually shorten, but they don't go back to the same length. They get fatter. So the uterus in itself just becomes shorter, bulkier, and the thickness as well becomes a lot fatter. We go through labour, you're having your contractions, they're every sort of 3 minutes. And what's happened in that early phase of labour is that these are regular contractions that you feel aren't doing anything. What they're doing is they're thinning out this part of your cervix and flattening it, so that what you see is this cervix that's maybe now 4 centimetres dilated, but paper thin. And as your labour progresses now, that hard work's been done, and it is a lot of hard work that your body's got to do. So now we have this part where the cervix now just has to thin out, and it's done that because the uterus has been pushing baby down as it's getting smaller, shorter, and the muscle fibres getting fatter. And that is what's happening in that early stage of labour. Being upright and mobile during this stage of labour will help to make it easier for your baby's head to apply that pressure. So if we think even just about gravity in itself, if you're lying down on a bed and you're on your back, this is the position that you're in. So there's no longer this pressure from baby's head here on your cervix. Whereas when you're standing or you're leaning forwards or kneeling or sitting on a toilet, you can see that that pressure of gravity is now applied to your baby's head. And that makes it more likely that your labour will progress. And being able to move and listen to your body helps your baby to descend in a more optimal position than being on the bed. So for various reasons throughout your labour, you may actually find that for whatever reason you are on a bed. So it may be your choice of pain relief, or it may be that you're really tired and that you do want to have a bit of a lie down and a bit of a sleep. So there are plenty of options to try and help support upright positions that can help to widen the pelvis. And you can also do them lying down. So if we look at a pelvis, what we have is we have this coccyx here. Now, when you're lying on your back, what's happening is this, and it moves, it's on a hinge. You move onto your side, onto your left side or your right side. So even if you've got an epidural, you just want to have a bit of a rest, there's not so much of an impact of that because it's allowed to move. Remember, if you're lying on your back, you've got the bed that's stopping that happening. So on your side, and there's an amazing thing called a peanut ball, and we love them, don't we? And it's a bit like a pillow, but it's this birthing ball, but it's shaped like a peanut, and it sits in between your knees. But what it allows to happen is just allows your pelvis just to open up that little bit more. So I think that's really important as well, that as much as we say, you know, stay upright, stay mobile, it's not always possible. And I think, you know, if you know that Even with an epidural, you may still be able to kneel. You may need a bit of help to get into that position, but it's still really important to understand that there are things that we can do to help, even if you can't move a muscle with your epidural, if it's really, really dense, that we can get you into a position whereby we can help to maximize the space in the pelvis in much the same way as we would if you were on all fours. Because all we really need to do is change the position of your knees. And it's that muscle that's attached in as you move your knee that these two bones come out. And you can try that at home. If you sit down and put your hands under your bottom and feel for these sitting bones, and then what you'll find is as you stand up, they move in. And that shows you that being in this position with your hips at an angle, so you've got 90-degree angle from your ankles to your knees to your hips. And it's that position that just helps to maximize that space in your pelvis. And the toilet as well, if you're sitting on the toilet, if you just put some books under your feet, it will raise your knees even higher, and that even gives, more space as well. So during labour, you'll be offered monitoring of your baby's heart rate, which is usually one of two types. Monitoring of your baby's heart rate during labour can help to reassure you and your midwife that your baby's coping well with labour. Now, although every hospital has their own guideline on this, it's ultimately your decision whether you consent to this monitoring or not. Now, the two main ways that your baby's heart rate can be monitored is either intermittently with a Doppler or continuously using a cardiotachograph machine or a CTG. Now, these are only usually used if you're in hospital, and they're usually only offered if there are concerns about you or your baby, either during pregnancy or that have come to light in your labour. Your uterus is the most powerful muscle in the human body, and it's helping the cervix to dilate in that first stage of labour by contracting. And your cervix will continue to dilate to around 10 centimetres, which is when it's open enough for your baby to descend and the second stage of labour to begin. Women will hit a part of labour called transition. Now, it's whether or not you actually feel this. So some women will feel it quite profoundly and other women won't even notice it. And it usually happens when your cervix is around 8 centimetres dilated to fully dilated. And it's usually at that point that women start to feel that they can't cope. And this is when they start to verbalise those feelings as well. So it's the time when most women would start to say that they can't cope, that they need pain relief. But that doesn't happen to everyone. But it's a really good sign that you're progressing well, and you should be encouraged by this. And your birth partner should be reassured, and by your midwife, that this is a positive sign and that you're coping well. Hypnobirthing and breathing techniques can not only help you cope with contractions during labour, they can also be useful for other situations or when you need focus and to stay calm and to help you make decisions. And ultimately as well, in that really fraught stage, just at the end, if you are experiencing a bit of stress and a bit of anxiety at that transition stage, then hypnobirthing is brilliant at just bringing you back down and just helping you to centre and refocus and stay calm. The important thing about transition is it's a really small amount of time, and your birth partner is really well placed to help you remind you that this will pass, that you just need to breathe, you just need to focus, and that tension will go. So we've looked at spontaneous labour, where your body's gone into labour under its own steam. For some women, they will approach 40 weeks of pregnancy, 41 weeks of pregnancy, and that just doesn't happen. Now, it's at that point that you may be offered an induction of labour. It may also be that your obstetrician has maybe identified that there are concerns with baby or with you earlier than that, and again, they may offer you the induction. So you've gone through your brain acronym, you've weighed up the risks and benefits, and you've decided that, yes, I would like to have an induction of labour. And we can do that in 4 ways. The first way is something called a membrane sweep. The second is using a hormone called prostaglandin, and that's inserted into your vagina as a pessary. The third is breaking your waters artificially, or artificial rupture of membranes. You'll see that written as ARM. And then finally, a hormone drip, syntocinon. Now, sometimes all 4 are needed, sometimes just the one. So it's very much dependent on how you labour yourself. So if we look first of all at membrane sweeps, so they're seen as the most natural option to get you into labour. And it really just involves a vaginal examination by your midwife or doctor, and they insert 2 fingers into your vagina to locate your cervix, and then they gently move the cervix and strip it away from the baby's membranes. Now, the risk of that is, if you're just about to go into labour, sometimes the membranes can be a bit more fragile. So there's a risk, and it is a small risk, that the membranes might actually break without you going into labour. And we would always prefer that you went into labour, your contractions started, were really efficient, and then your waters broke, rather than the other way around. The other risk is that we know just under half of women that have the membrane sweep will go into labour within 2 days. So for those that don't go into labour, what they can sometimes have are periods of maybe 8 to 12 hours where they'll have contractions and then they'll stop. And that can be quite tiring and quite disheartening for them as well. Your cervix also needs to be open far enough for them to be able to actually insert 1 or 2 fingers. So again, if your cervix is closed, they won't be able to do a membrane sweep. And as well, if baby's head's still quite high in the pelvis, it won't be safe for them to do so. The next option in this sort of journey to induction is a prostaglandin pessary. Now that's done in hospital. Now, some hospitals actually allow you to go home, depending.
Yes, so once it's been inserted and then returned within 24 hours afterwards. So the prostaglandin pessary comes in 3 different forms. It can come in a tablet, in a gel, or in a string that's impregnated with this hormone. Again, it's the same vaginal examination, reaching for your cervix again and putting that hormone just behind your cervix to help it to work, to soften your cervix, to get it to a point where we can break the waters. So it's not really something that's going to start your labour off spontaneously, although it can do in some cases, but it is to get your cervix to a point where they can do a vaginal examination and the waters can be broken.
And they do like the cervix to be really quite open and quite thinned out by then as well. So they do like it to do quite a lot of work, their prostaglandin. I know I have seen women labour really quite well. And there's some hospitals that, as well, that would say, actually, you can have this and go home, or, you know, if you want, and you've gone into labour, treat you as spontaneous labour. So not having to have that same level of monitoring and things. Yeah. And then we have artificial rupture of membranes after that, which is breaking your waters. Now, if you look at this, the hook, it's the tiniest little edge on it, little point on it. And when a midwife's actually doing this, what they do is they actually run it on the inside of their finger. So you can see that that's not actually any larger. And the fingers are inserted, the membranes are located, and when you can actually just feel a little bit of pressure in the membranes, what then happens is we just turn the hook around, press really gently, and that's usually just enough to make a little hole, and then we can just insert a finger and make that larger. And then we turn the hook back around and we take our fingers back out. And it will feel like you've wet yourself, because there will be lots and lots of waters that come away. And then we change your pad, and we would encourage you just to walk about. And, you know, for some women, their labour will start straight away just with that. And for some women, when they come in, they don't need the membrane sweep, they don't need the pessary. When we move on to that next stage with the Syntocin or the hormone drip, that is when you become really quite medicalised. It really steps up a gear, doesn't it, with monitoring of baby, because we're really sort of into the realms of doing it very artificially now.
Then the next step will be to firstly monitor your baby continuously. So you'd have the belts on, monitor a baby's heartbeat, monitor your contractions. Then you'd need to have inserted into usually your hand a drip, so a cannula in here, so which is just a tube. People think it's a big needle, but it's not. It's just a little tube that ends up being in your hand there. And then there'll be a continuous drip that feeds in this hormone. And that hormone will do what your oxytocin hormone, which would have started off your labour naturally, this is the synthetic version called Syntocin, and it will produce those rhythmic contractions for you. And it's built up quite slowly, so it doesn't come on suddenly. they'll build it up quite slowly because they don't want to stress your baby or your body out. So they want the process to be like a normal labour, but the build up to be slow.
When we start the drip, we don't expect the cervix to open much at all really in that first 4 hours. We usually have to sort of wait until your contractions have got that nice pattern of maybe 3 or no more than 4 contractions every 10 minutes. And once we get to that stage, we're looking for your cervix to start to dilate at quite a reasonable amount. So the rule of thumb has always been 0.5 to 1 centimetre an hour. But for some women, it will maybe be 4 centimetres an hour. So it's very much dependent on you as a woman and what your body's doing. It's when we start to find that the cervix, no matter what we're doing with the hormone drip, the cervix is just not opening. And that's one of the risks with induction, that once we get down into that pathway of starting that hormone drip, that it's very difficult to rewind it. Although there are occasions that we can sort of switch it off and just let you see if your body will take over. And, you know, sometimes that's a tool that's used to quite good effect, actually, that just by switching it off, something in your body just takes over, and then your own natural oxytocin hormone
it's more likely to be successful than unsuccessful, though, isn't it?
Yeah.
To get you to labour.